unstable systematic disease, unstable endocrine, renal, cardiovascular, pulmonary, or hematological diseases. See, if these are stable, or we can reverse the condition for the extraction being, then extraction can be done. These are not the absolute contraindications as far as anything is concerned. Then local conditions such as radiation therapy, malignant tumor, damage to the vital structure, pre-surgical assessment, medical risk management assessment, emotional condition, clinical evaluation, radiographic evaluation, overall difficulty, surgical approach. So what is clinical evaluation? So the first thing you will see is the excess. How you can see, or how can you can locate the clinically the tooth. Okay. It is SS is for anything. If you are doing a root canal treatment, you have to assess to prepare the SS cavity and all. Okay. Then status of the support structures, the tooth you want to extract, whether surrounding tooth are present. What about the condition of gingiva? Okay, what is the bone support clinically? Status of tooth and crown, whether the crown is broken one, whether there is a root caries, okay, whether the tooth is splitted or fractured. Can you hear me?
Yes.
Adjacent structures. When interpretation of pre-operative radiograph, it requires the normal knowledge of normal radiographic anatomy. Okay, now what is radiographic anatomy? Some things which you can see radiographic only. Okay, like you can't see clinically inferior alveolar canal, but radiologically you can see the canal. Okay, so in your setup, you do OPG of each and every patient?
No.
Okay, of third molar patients? In which?
Yes.
Yes. Most of the patient you do OPG?
If require extraction, yes.
If require extraction, yes. So how many cases are there like that you do OPG of? Do you have records?
Every day?
Do you have OPG records?
Yes, we have the system. It's the digital system.
Digital?
Hmm.
Okay. You have digital records of OPG, correct?
Hmm. Yes.
So your after your this extraction, then impaction, the third molar thing is over. I will give you the topic for your dissertation, okay, or your project topic.
Okay.
It will be related to OPGs only, so don't lose the OPGs. Okay. So the knowledge of the normal anatomy, then assessment of the condition of surrounding bone, assessment of adjacent vital structures, assessment of condition of adjacent teeth, and assessment of tooth in question. Then what is the way, what is the sequence of extraction? First, local anesthetic, then wait for the optimum effect of local anesthesia, excess visibility, light, retraction, suction. There should not be clutter like saliva and all. Your forceps might get slipped there. Then again excess. Then periosteal elevator, reflect the papilla and sever the periodontal ligament. If required, luxate the tooth. Forceps luxate to expand the socket. rotate to sever the PDL, traction to deliver the tooth. Squeeze the alveolus, and if required, suture the periodontal area. Then post-operative instruction and medicine should be there. So what are the fundamental requirements is first thing is access of the area, good visualization of the field, unimplanted pathway of delivery of the tooth. See the roots, you have to check the pattern of the roots. Control forces to retract adjacent structure and remove the tooth. Your position should be standing or sitting. Are you comfortable with standing position or sitting position while extraction?
Sitting.
Sitting, okay. I do all my procedure in standing, even in implants. I do standing. So the positions are in front of the patient or behind the patient. See, when you are targeting, you are right-handed or left-handed?
Yeah, right-handed.
Right-handed. If your target area is quadrant 1, quadrant 2, and quadrant 3, then you are standing in front of patient.
Right.
Okay. And if you are doing at quadrant 4, like lower right, okay, then you will stand behind the patient.
Right.
The patient almost supine 10 degree from the ground for maxillary teeth and semi-sitting to the ground. Back should be straight, head should not be bent. If required, mouth props given. So what type of periostal elevator you are using for retraction? Do you use?
I think it's Minnesota.
Okay, you use Minnesota. We use Austin. Plain periodontal periostal elevator. Then suction is used. You should use a metallic suction here. Okay, not with the fiber suction. Keep finger on hole for exodontia. Place an area of dependent drainage. Avoid random suctioning. See, the dependent drainage, most of the time in maxilla, it is from the extraction socket only. Okay. And from mandible, it may be from the extraction socket if the flow is more, or if the flow is less, the dependent drainage is through the buccal cortical bone or the lingual cortical bone, whichever is severed in the extraction. So if you are not using the suction properly, or it is kinked in between, so then at that point your suction is not proper, the visualization will be impaired. Okay, so always use your suction at the right place. Okay, and use a metallic one while doing the extraction. You can use a fiber optic one, there is no harm, but make sure it is a good suction. Okay. And irrigation, you can do irrigation with normal saline. Okay, you should keep that normal saline in the refrigerator. It is a hypotonic solution, so it will when you are irrigating, what a hypotonic solution will do, it will take all the inflammation out and sodium is imbibed inside. Okay, it will act as a coolant also, a lubricant also, and a cleanser also. So when you are doing an extraction, if you are taking an incision, your BP handle and blade should be of pen grip. Okay, you should hold your BP handle and blade like you hold a pen. So the 15 number of blade perpendicular to mucosa or skin. It should not be like this or this. It should always be perpendicular. Why it is perpendicular? Why it should be perpendicular? So that it should not give any.
Can cut all the way to the bone.
Yeah, and it should not give any ragged margins. Okay, ragged or irregular margins. You should give in one smooth stroke. Do not do like this. It can convert many micro incisions. Then elevation of periosteum. The periosteal elevator is used. Sometimes malt elevator is used. Sometimes Austin elevator is used. Full thickness flap should be raised. Okay. Full thickness flap should be raised. Then severe the crestal PDL and subperiosteal dissection should be there. Okay. Broad end of the this is after the some of the bigger cases. You can it can be used for a retraction also, the broad end of the periosteal elevator. Okay, not for exodontia. For exodontia only small end is used. You initiate the flap, sever the crestal PDL, elevate the papilla and subperiosteal dissection. So can you see this pic? This is how you initiate the flap from here, refract the papilla and severing the PDL. Okay. Reflection of papilla. Papilla is here. This is the papilla. First you will retract the papilla and then sever the PDL. Now various elevators are used. For first thing is for the luxation of the tooth, for tooth delivery. So while you are elevating and all, do not lean on the adjacent teeth. Okay, you may see the periodontal of the adjacent teeth which is not required to be extracted. Alveolar bone should be used as fulcrum, not the adjacent teeth. Sometimes people are using adjacent teeth as fulcrum. Do not use adjacent teeth as fulcrum, only use alveolar bone as fulcrum. Your forces should be controlled. It's not like that you are forcing like from the buccal side, you are forcing very hard and go to perforate the lingual side and turn. Okay, sometimes it happens. So whenever you are placing an elevator, your one finger of the other hand should be guarding the tongue from the lingual aspect. Correct? Now this tooth should to be extracted. So we are not taking support from this. We are taking support from the alveolar bone. The movement of the periosteum should not be like elevator should not be like this. It should be wheel and axle principle. Okay, wheel and axle principle. So elevator, alveolar bone and bone as fulcrum. This is the position of the elevator. Can you see the cursor? This is the position, not this.
Yes.
Okay, this should be the position of the. In forceps extraction, choose handle for access, comfort and leverage. Choose beak of adaptation to the tooth. So proper placement and apical seating, controlled steady forces, hold at the end of handle for greater leverage advantage, feel what direction tooth wants to come out and go with it. So in forceps extraction, first of all, apical force is there. Okay. After you are giving the apical force, then expansion of the socket. See, this is the tooth which is in the socket. When you expand the socket, what will happen? It will get loose. Okay, expansion of the socket and then take it out. Avoid fracturing these surrounding bone. So first is when you are doing forceps, when you are applying the forceps to the tooth, wedge action is there. Okay, wedge action is there. You are severing it. Wedge action is there, like this. So when your forceps is going down, automatically opposite reaction is the tooth will slightly come up if your forceps is going in the right direction. So first basic movements are, first is apical pressure, then buccal portion pressure, then slightly lingual pressure, then rotation and then traction. Okay. Apical pressure, buccal pressure, lingual pressure, rotation, traction. In multi-rooted teeth, you will not rotate. In multi-rooted teeth, you will not give rotation pressure. Correct?
Yes.
Now, what should be your grip? It should be maxillary pinch grip. For maxilla, see, can you see the hand? Okay, in maxilla, index finger is on the buccal side, thumb is on the palatal side, and then you are applying the forceps. Okay, it's a pinch grip. In mandible, it should be a sling grip. See, the middle finger, it is on the buccal side. The index finger, it will palpate the lingual side, and for the your hand, okay, all the three fingers, they are supporting the mandible. All three fingers, these three fingers, they are supporting the mandible. Now maxillary forceps. So in maxilla, various kind of forceps are used. Some forceps are universal forceps. Universal forceps are those forceps which can be used on the both the sides. Okay. And both the sides means both right and left quadrants. Okay. Those are universal forceps, such as maxillary anterior forceps and maxillary premolar forceps. But from molar onwards or molar forceps, those are not universals. Those are site specific. Okay. Mandibular forceps, all the mandibular forceps are universal forceps. Okay. So in mandible, for simple extraction, the forceps are mandibular anterior forceps, which can be used for anteriors, mandibular premolar forceps, which can be used for both side premolars, and then mandibular molar forceps used for both side of molars. Apart from that, there is a cow horn forceps. There is a cow horn forceps for caries tooth extraction. In maxilla, 1, 2, 3, 1, 2, 3 for anteriors, same forceps are used. For premolars, yes, universal forceps that can be used both the sides. But for molars, the forceps are different for both the side, and for cow horn also the forceps are different for both the sides. Okay. So how to handle a soft tissue? The tissue pickups or the tooth forceps or non-tooth forceps, the tooth forceps will limit the tissue damage. The non-tooth forceps, it will crush the tissue. Okay. For simple extraction, you don't require any flap for suturing. You can simply press the socket. Now, when to leave root fragments? Okay. When it is lesser than 5 millimeter of length, you don't have to take the small root, apical root stump out, because when you are attempting it, if it is coming easily, then it's okay. But if you are attempting it, then what will happen? You can you may damage the surrounding tissue more. Okay, you may damage the surrounding tissue. The root fragment must not be superficial. If the root fragment is superficial, then you should remove it. If it is not superficial, it is very deep, then don't damage the surrounding tissue. You can leave it. Tooth involved must not be infected or have apical lesion on radiograph. If the tooth is having apical lesion on radiograph, then you have to remove the root stump. If it is not having any apical region on the radiograph or it is not infected, then you may leave it. Okay. If the root stump is near a vital structure, if you are removing a third molar and the apical root stump, it is very near to the alveolar bundle, okay, or the canal, then you may leave it. If it has, this is for the upper one, if it has potential to be displaced into sinus, inferior alveolar canal, or submandibular space, or would require destruction of excess bone. See, the main thing is that you should not damage the surrounding tissue while removing a small apical fragment of root stump. Okay. So for upper, if you are trying and it goes into the sinus, then there is no use. Okay. So you can leave it behind rather to perforate the sinus. Now, what should be the order of extraction? Simple. You should extract the hardest teeth first. Okay. Harder to freeze, last to allow local anesthetic and time to work. Always do maxilla before mandible. If you are doing extraction on both the jaws, like on maxilla and mandible, also both, you should extract maxilla before the mandible. First thing is that the anesthesia, it will act faster on the maxilla. Okay. Now, if you have extracted mandibular teeth and then you are extracting the maxillary teeth, what will happen? When your mandibular socket is open, okay, your mandibular socket is open and you are extracting the maxilla after the mandible, what will happen? All the calculus, all the debris, it will fall into the mandibular sockets. We don't want that. Okay. So extract the maxilla first, then mandible. Always do posterior teeth before anterior teeth. Those were the various principles of extraction. Okay. Now, what is an extraction is? So, from all this, we can conclude that ideal tooth extraction is the painless removal of whole tooth or tooth root with minimal trauma to the investing tissues. Okay, so that the wound heals uneventfully and no post-operative pre-prosthetic problem is created. Okay. What about to the Peterson? It is the retrieval of tooth root and teeth that is likely to fracture or for some or other reason have an obstacle for extraction. Okay. Now these are the various indications of extraction in simple language. Severe caries, pulpal necrosis, severe periodontal disease, orthodontic lesions, malpose teeth, cracked teeth, and pre-prosthetic extractions. Impacted teeth, supernumerary teeth associated with pathological regions, pre-radiation therapy, teeth involved in the fracture jaw, aesthetics and economics. These are the local indications, contraindications, therapeutic radiation for the cancer, teeth located within an area of tumor, severe pericoronitis, damage to the vital structures. Acute dental alveolar error, it is not contraindication for extraction. In fact, rapid resolution of the infection is obtained after removal of the infected tooth. So you have to do a controlled extraction. Controlled extraction means you give patient pre-operative antibiotics for 1 day. Okay, so that the localized area should be in control and then go for extraction. In systemic contraindications, unstable endocrinal, renal, cardiovascular, pulmonary or hematological disease, patient under variety of medications. And it is a relative contraindication on pregnancy also. Now chair position of the patient, operator and the chair are critical for successful completion of the extraction. A proper chair position allows the maximum control over the force that is being delivered to the patient through the forceps. The correct position allows the surgeon to keep his arms closely to the body, provide support and stability, and to keep the wrist straight enough to deliver forces with the arm and shoulder, not with the hand. So your action should be like this, from the shoulder, not with this. Okay, do not do like this. It should be force from the shoulder. For maxillary extraction, the chair should be tripped backward so that the maxillary plane is at 60 degrees to the floor. The height of the chair is such that the mouth is slightly below the operator level. The site of the operation is about 8 centimeters below the shoulder level of the operator. And according to Archer, the occlusal plane should be 45 to 90. For 45 for maxillary and 90 for mandible. So mostly we follow Archer. Okay. For maxillary right quadrant, here. The patient head should be turned substantially towards the operator, like, see if the operator is here. So the head should be turned like this. Okay. For maxillary left quadrant, the patient head is turned slightly towards the operator like this. Maxillary anterior portion, the patient should be looking straight like this. Maxillary anterior, patient should be looking straight, not tilted. Now you can see the placement of finger, pinch grip. This is called as pinch grip. We have discussed earlier, this is called as pinch grip. Can you see? Index finger, thumb. Index finger, thumb. Thumb, index finger. For the right side, the thumb is on the buccal side. For anterior and left side, the thumb is on the palatal side. Correct?
Hello.
For mandibular extraction, see the movement of finger. The thumb is at the palatal side, index finger outside. For anteriors, middle finger and index finger. For left side, middle finger and index finger. Middle finger is on the palatal side, index finger on the buccal side, and thumb is supporting the mandible. Mandible support is it is a requirement for mandibular extraction. Okay. There are many cases when you are not supporting the mandible, dislocation is there. Sometimes fracture of mandible is there if you are not supporting the mandibular enough. So placement of fingers we have already done. Mechanical principles are lever principle. The mechanism for transferring the modest force with the mechanical advantage of lever arm. You see that the lever arm, it diverts your force to the maximum. Okay. You are applying, suppose you are applying to the grade of force 1. Okay. It will deliver as force 4. Okay. It can increase your force 4 times. Wedge is the simplest form of movable incline, as we have seen in the figure, that you apply the forceps, it should be in the wedging position, so that the tooth automatically slightly will come out. Third is wheel and axle principle. What is wheel and axle principle? When you are applying a elevator, okay, you are applying an elevator and rotating it. It is called as wheel and axle principle. Your all elevators work on this principle. Your crossbar elevators, they are working on this principle only. Principle of forceps. First is wedging, then expansion of the socket. Okay, the first force is apical pressure. I have told you 5 forces. First one is apical pressure, second is buccal pressure, then palatal or lingual pressure.
Lingual.
Yeah, then rotation and then traction. Okay. So apical pressure, it causes bony expansion. Center of rotation of the tooth is displaced apically. Buccal pressure, it results in the expansion of the buccal plate, particularly at crest of the ridge. It also causes lingual apical pressure. Lingual pressure or palatal pressure, it is aimed to expanding the lingual or palatal crestal bone. It also causes buccal apical pressure. Rotation pressure, it causes some internal expansion of the tooth socket. Curved roots are more likely to fracture. So don't apply rotation on multi-rooted teeth or curved root. And traction forces, they are used for delivery of the tooth out of the socket after adequate bony expansion is achieved. It should be gentle and limited to the final proportion of the extraction process. Again, these diagrams. Okay. Now, procedure for close extraction. Two objectives are accomplished in the dental extraction: expansion of the alveolar bony wall, okay, to provide unimpeded pathway of the tooth, tear of the periodontal ligament fiber so that the anchor tooth in the bony socket. Close the extraction technique. Close extraction technique is also known as simple or forceps technique. Simple or forceps technique. When you are using a word close extraction, it is a forceps extraction. And when you are using an open extraction, it is used as transalveolar extraction. Correct? Technique used for close extraction can be generalized into 5 steps. Loosening of the soft tissue attachment from the tooth. This allows the surgeon to ensure that the profound anesthesia has been achieved. Okay. And it allows the forceps to be positioned more apically without any impingement on the soft tissue of the gingiva. Luxation of the tooth with the dental elevator. Okay. Now this elevator is working on wheel and axle principle. Wheel and axle principle. Adaptation of the forceps to the tooth. When you see this black one, this is forceps beaks, transverse section. So beaks of the forceps must be held parallel to the long axis of tooth. Okay, if you are not parallel to the long axis of tooth, the crown may get fractured. The forceps is to be grasped firmly with the wrist, lock, and arm held against the body. The force should be applied with the shoulder and upper arm without any wrist pressure. Okay, the correct grip of the forceps is the thumb is just below the joint of the forceps. The forceps handle in the palm. The little finger is placed inside the handle and used to control the opening of the forceps blades during the application to the root. When the tooth is gripped, the little finger is placed outside the handle. When luxation of the tooth with forceps, slowly you will increase the force and microfractures are created, alveolar bone expands and forceps are more receded apically. The forceps will go more apical. Traction force is used for removal of the tooth from the socket. This is the last motion exercise once the alveolar process is significantly expanded. Periodontal ligament is completely severed. For malpose and unusual position of the teeth, luxation and removal will be in unusual directions. What are the common errors in forceps extraction? Failure to grip the root. Okay, sometimes we are just gripping the crown and trying to extract and the tooth will go for a fracture. Incorrect alignment of the forceps blade along the long axis of the teeth. If your blades are not aligned to the long axis of the teeth, or if they are not parallel, then what will happen? It may get fractured, yes, or crushed. Specific techniques for removal of each tooth. For maxillary incisors, conical root, mostly rotation. Lateral incisor, distal curvature of the apical third is there, so don't do rotation in lateral incisors. The initial movement is slow, steady, firm, and then labial direction. Less vigorous palatal force by slow rotational movement after the labial expansion is done. Tooth is delivered in the labial incision direction with small amount of traction force. For canine they have long roots and thin labial plate. The labial plate of canine is thin. So initial movement to the buccal aspect with the return pressure of the palatal, apical repositioning of the forceps again, small amount of rotation force in the canine, and tooth is delivered in the labial incision direction with labial traction force, slightly like this, not like this, slightly like this. You are coming with the tooth. The premolar single-rooted in the first 2/3 and bifurcation to the buccal and palatal is seen in the apical third. The premolar, the bifurcation of the premolar roots are in the apical third. Fracture may occur readily during the extraction. Initial movement should be buccal. Fractured palatal root tip is harder to retrieve in. We see this happens in most of our orthodontic cases because those mostly the orthodontists they tell you, do not fracture the bone, do not fracture the bone, and the surgeon is already in the anxiety, and most of the time it happens that the root piece is left behind. then we are taking the root piece out, and so sometimes you may spend more time extracting orthodontic extraction rather to extract third molars. Yeah, it happens. Most of the time it happened with me also. The orthodontist, they
So so doctor, you know what I do? Let's say if the patient needs orthodontic extraction, what I do is I place the bracket there first for a month, and then the tooth will become a bit loose, and then you extract it.
Okay, nice. You place a band there.
No, you just start with the orthodontic treatment first. You place the bracket, you place the wire, and then because there will be orthodontic movement, so it will be slightly loose. So when you extract it, normally it won't fracture.
Okay, that's a good idea. See, learning has no limits. That is good. So for second premolar, single rooted tooth, root is thick and has a blunt end. Rarely fractures, relatively strong movements are required. Maxillary molar, the first molar, 3 large roots are there. Buccal roots are relatively closer and the palatal root diverges towards the palate. Radiograph should be evaluated for the size of root, curvature of root, divergence of root, relationship to the maxillary sinus. Okay. The forceps have projections on buccal beaks which fit into the bifurcation. The upper crown forceps are usually, in the case of large restoration or caries. Basic extraction movement is to use strong force buccally and return to palatal. Don't go for the palatal force. Do buccal force and return to the normal. This prevents the fracture of the palatal root, which if fractured is difficult to retrieve. Most of the time, the palatal roots are very difficult to retrieve. For second molar, the technique is similar to first molar, except that it is easier to extract due to shorter and less divergent roots. The third molars, conical roots, frequently extracted by use of elevators alone. Preoperative radiograph assessment is very important in these cases. For mandibular teeth, anterior, fine roots with flattened sides, easy to extract, but sometimes very brittle. They may get fractured. Okay, the fine blade forceps are used. Initial movements in the labial and lingual direction, followed by rotational movements, and the tooth is delivered into labio-incisal direction. In mandibular premolars, they have a tapering roots. Their apices may be distally inclined. Basic movement is towards the buccal, returning to the lingual, and finally rotational movement. In mandibular movements, molars, 2 roots are there. Okay, roots of the first molar is usually divergent. So overlying bone is heavier than the bone on any other tooth in the. See, for the mandibular first molar, it is there. Now overlying bone is very thick. See, first molar and canine. First molar and canine in maxilla, first molar and canine in mandible, they act as these 4 act as pillars of the jaw. Okay, pillars of the facial bone structure or architecture. Okay, so these 2 should be extracted in the last. If you are extracting from the order of extraction, if you have to extract all the mandibular teeth of one quadrant at one side, then third molar, second molar, then not first molar, then you extract second premolar. Okay, then extract first molar, then first premolar, lateral incisor, then canine, then central incisor. You got the order of extraction? Canine and
Yes.
first molar, they have to extract it after their adjacent, both the teeth are removed. Okay. So this is the beak of the forceps, molar forceps. Okay. Can you see?
Yes.
How to use cow-horn forceps? The beak of the forceps was squeezed into the bifurcation. This creates the force against the crestal alveolar ridge on the buccal lingual aspect, and literally the forces that put directly superiorly out of the socket. In third molar, variable root pattern is there. A radiograph is essential. A radiograph is essential nowadays in each and every extraction. Okay. Lingual cortical plate is thinner than the buccal cortical plate. The tooth is delivered into linguo-occlusal direction. Sequence of extraction, as we have already discussed. See, one pattern says that hardest tooth should be extracted first, and other pattern says that difficult tooth should be extracted last. Both have different views. When you are extracting, see if a patient of third molar surgery, which have to extract both the third molars, okay, it comes to the clinic. There is no pain as such in any of the tooth. Then what should you do? Those are prophylactic extraction. What should you do? You extract the easier one first, then give a gap. Okay, it will build up the confidence in the patient also. It will build up the confidence in patient also. Post extraction care, the socket should be debribed only if necessary. Okay, careful curettage of the periapical lesion if visible on radiograph. Obvious debris such as tooth fragment, calculus, amalgam must be gently removed. Expand the buccolingual plates should be compressed back to their original configuration. Approximate them even more closely if possible. The sharp edges of the bone to be smoothed out with the bone file. To gain control over the hemorrhage, moist gauze should be kept over the socket so that it fits into the space previously occupied by the crown of the tooth. Instruction to the patient. The patient has to, the gauze pack should be for half an hour to 45 minutes after the operation. Why? Why you give?
To stop the bleeding.
To stop the bleeding.
To stop the bleeding.
What is the ideal bleeding time?
Compression.
What is the ideal bleeding time? Why should you?
Ideal bleeding time.
Yeah.
I think 20 minutes, right?
Bleeding time? No, 20 minutes. The patient will bleed. Ideal bleeding time is 2 to 3 minutes. And clotting time is 6 to 7 minutes. Okay. In 6 to 7 minutes, the blood will clot. Okay. Then why we are keeping this for 45 minutes? See, if the blood is blood clots in the socket, then why you are keeping the gauze for 45 minutes?
To give them compression.
For what?
To prevent the blood clot from falling out.
Yes, there is after this clot retention time is there. Okay, the clot retention time it is half an hour to 45 minutes. The clot retention time is what? So bleeding time is different, clotting time is different, and clot retention time is different. Otherwise, what will happen? The clot is there, but it will flow out of the socket. So the clot retention time is 45 minutes. Okay. Mouthwash to be avoided for 6 hours after the surgery. We tell patient to avoid it for 24 hours. Okay. Application of ice cap intermittently on the first day only. This will give a soothing effect. The day after operation, apply heat at least for 4 hours. Okay, so we tell patient to do lukewarm water plus salt added rinses. Lukewarm water saline rinses. Okay, so saline will act as a hypotonic solution and it will reduce the inflammation. Okay. So anything? Yeah. So anything you should, you want to learn more in extraction? We are not
Yeah.
over the third molar now. This is for the simple extraction, close extractions.
No, everything is okay.
Everything is fine. Okay. Then in next class, we'll start for the third molar on Friday.
Okay. Okay.
Okay. Third molar extractions, we will start on Friday. Correct?
Okay.
Yeah. So take care and see you on Friday.
Okay. Bye bye.
Bye bye bye. Take
Okay. Thank you.
care. Bye.